All right. So having experienced a lot of electrical stim, now we want to just delve into the nitty-gritty. The major indications for electrical stim, which are muscle strengthening and pain management. Those are really our major considerations, even though there are some subcategories within that. Um, that is normally what we're going to be doing with eStim. So we'll start with muscle strengthening and then we'll have some separate lectures on pain management. So for this section, I want you to be able to state the 6 clinical applications or clinical indications for electrical stim for strengthening. And we're going to base these on desired outcomes of the treatment. Okay. We want to know the differences between voluntary physiological muscle excitation and electrically induced excitation of skeletal muscle or evoked muscle contraction, and the implications of the treatment with neuromuscular electrical stim. So we talked about this briefly in the introductory lecture, and I'm just going to talk a little more about it. So neuromuscular electrical stim can be used when impairments in structure or function are identified that require modification of neuromuscular activation and control. So the activities that are impeded by these impairments are identified that impact the participation in life roles. So just strengthening a single muscle isn't our goal. Our goal is to improve function. And so functional goals want to address the activities component. So how is strengthening this muscle going to improve the person's function? And modification of the impairment by neuromuscular electrical stim might permit the client to participate more fully in life roles. So a good example of this that I've seen in the clinic is we'll use the functional electrical stim bike, and there are lots of different reasons why you want to use it. So you have two 6-channel stimulators, so you have 12 channels, and you set them up for functional activity. So you have electrodes on quads, on hamstrings, on glutes, on tibialis anterior, on gastroc, on you can have channels on abdominal muscles if that's something that you're working on. So all of those stimulator activities allow the person to ride the bike, but then we have to translate that into functional goals. So you can set up a program based on what you did with the functional electrical stim bike to do electrical stim with something like sit to stand, a functional activity, or reaching activities if you're doing upper extremity functional electrical stim. So there are reasons why you might want to set that you do the activity just to improve strength, but then you have to branch it over into functional goals so it allows the client to more fully participate in their life roles. So we have to bridge that gap between just plain old strength and functional strength. And that goes for everything, not just for electrical stim. It goes for all the activities we do in therapy. So the 6 indications are to, but in the learning objectives, are to increase muscle strength, to enhance performance in healthy muscle, which we rarely do in PT, just saying, to improve muscle endurance, and the functional electrical stim bike is a good example of that, to facilitate range of motion, to modify spasticity, and or to enhance motor control. So functional electrical stim, facilitating a purposeful movement or substitute for a passive orthosis. So the orthotics that give the electrical stim to perform the functional activity. So this is an example of that. There's the one on the right is a typical non-functional electrical stim orthosis that is a passive orthosis that keeps the hand in extension, usually used after someone's had a stroke. The functional electrical stim one actually stims the extensor muscles to get you into that motion. So it adds that little enhancement. So just to review the muscle strengthening in innervated muscle. So this is it, we're stimulating the nerve to create the muscle contraction. So the action potential is propagated along motor nerves. It crosses the neuromuscular junction. The muscle contracts. So with a physiologically initiated contraction, our normal muscle contractions, the slow twitch type 1 muscle fibers are activated first with a low contraction force and a slow speed of contraction. It's fatigue resistant because the nervous system chooses only the muscle fibers it needs and no more. It's atrophy resistant because, again, only the muscle fibers you need and no more. And the recruitment is asynchronous. It doesn't recruit all the muscle fibers at once. It just recruits the ones it needs. And there's where the nervous system comes in handy. It's complicated and it can do complicated things like that. So, in an electrically stimulated muscle contraction, fast twitch type 2 muscle fibers are recruited first with high contraction force and fast speed of contraction. That leads to the muscle fatiguing quickly and atrophying quickly. And it's a synchronous recruitment. So the electrical stim recruits all the muscle fibers in the area all at once. So when you normally go to pick something up, your muscles don't go all contract at once. It's a graded response. But with electrical stim, they do and all contract at once. So there's a difference between, and the muscle fatigues more quickly, and that's really relevant for the functional part of the treatment. So in just to reiterate, the voluntary or physiological elicitation of muscle contraction, the intercellular activation of small motor units is served by small diameter axons, and those are activated first. So there's a predictable order of recruitment from small type 1 muscle fibers to large type 2 axons and motor units. So the small axons are more fatigue resistant, and fatigue occurs only during high intensity voluntary contractions. Asynchronous activation of multiple motor units, so you're not activating them all at once, you're doing it as needed. And you get a smooth functional contraction. So, like I said, when you pick it up, your muscle doesn't just yikes contract. So, the electrically evoked muscle contraction using transcutaneous stimulation of a peripheral nerve, which is we do with eStim, you get a stimulation of mixed nerves, both sensory and motor axons, right? So you don't get a huge sensory response when you're voluntarily, physiologically contracting a muscle, but you sure do with electrical stim. So pain may accompany stimulation. You might have to turn up the stim enough to get a functional activity that it is borderline painful. So that's just something to know. And I'm sure we all experienced that in lab. And it's something that you should, if you're doing functional electrical stim with a patient, you should let them know that it can be kind of painful. And it has to go with their tolerance and how much muscle contraction you're getting. So there's a lot of individuality to the treatment. There's an unpredictable order of recruitment, but type 2 large fatigable axons and motor units may be preferentially recruited. And the axons closest to the stimulating electrons are most readily recruited in a non-selectively spatially arranged fashion versus the physiological selective fashion. And the axons are activated synchronously. When the stim goes on, boom, you activate all the axons. The potential to activate type 2 easily fatigued motor units at lower contraction intensities results in an earlier onset of fatigue. And contractions lack smooth grading and functionality. So it's a fast, non-selective contraction. So it's not quite like a physiological contraction. The other thing to think about is a physiological contraction, the message goes from the prefrontal cortex down the upper motor neuron, the spinal cord, down the lower motor neuron to the muscle. And there's a lot of control points in the pathway. With electrical, and it goes one way too, it goes from the brain to the muscle. With the electrical stim, there aren't any control points in the pathway. The thalamus doesn't get involved. None of the other control mechanisms become involved, and it goes all directions. It doesn't just go one direction, it goes multiple directions. So there's a little bit, obviously, difference between an electrically evoked muscle contraction and a physiological muscle contraction. So with the electrically stimulated muscle contractions in innervated muscle, where we have the nerve going to the muscle, the action potential is propagated along motor nerves, and fast twitch type 2 muscle fibers are activated first. Okay, we said that. In denervated muscle, electrical stimulation needs to have a pulse duration of at least 10 milliseconds, which is 3 orders of magnitude longer than the microseconds we need to stimulate innervated muscle. And it stimulates the muscle cells directly. So instead of going through the nerve by the neuromuscular junction to the muscle, it goes right to the muscle. Okay. So the reason we want to use electrical stim for denervated muscle is you might slow or reverse the loss of strength and atrophy, and the formation of fibrosis in a denervated muscle requires that long pulse duration using direct electrical muscle stimulation. Usually for denervated muscles, we use continuous direct current. And that's one of the only, besides iontophoresis, that's one of the only applications for direct current. Um, uh, Improvements in functional outcomes are probably not going to persist after stimulation of the denervated muscles, but sometimes it's worth it to prevent atrophy. So I have worked with people that had either traction injuries or anoxic brain injuries where they had denervated muscle that was eventually going to improve. And so doing this type of muscle stim just to keep the muscle going until it gets reinnervated, especially with the traction injury. With anoxic brain injuries, you're not necessarily going to get reinnervation, and then you might have to look at some other reasons or other types of interventions and what your reasoning is for doing it. A lot of times, even with someone with a complete spinal cord injury, doing something like a functional electrical stim bike can just help them overall in terms of their health and decreasing spasticity and improving, preventing atrophy, and improving circulation. So there are reasons for doing electrical stim that don't involve restoring function to the area. So just like when we're doing any other kind of muscle strengthening, electrical stim strengthens muscles by the overload principle. So an increased pulse duration, amplitude, electricize external resistance creates a higher load and a higher force of contraction and greater strengthening. Specificity, if you're specifically strengthening fibers that contract, electrical stim has more effect on type 2 muscle fibers than type 1. And disuse atrophy is primarily of type 2 fibers. So that's a reason why using electrical stim to prevent disuse atrophy is a good intervention. But the strength that you build with electrical stim isn't functional strength. Okay, that's something to think about. So neuromuscular electrical stim is not a substitute for voluntary muscle activation. It's not like you could say, oh, well, I don't feel like working out, I'm just going to put the e-stim on. You still have to do voluntary muscle activation is the goal. Evoked muscle contractions fatigue more quickly, secondary to early recruitment of type 2 motor units and synchronous excitation. They You want to select stimulation parameters that minimize fatigue. So you're going to look at the frequency, the on-off time, so you have those rest periods, and progressive strength of contraction. So again, neuromuscular electrical stim is not a substitute for voluntary motor activation. We have other goals that we're trying to achieve with it. So here's what we're going to, when we're doing the neuromuscular electrical stim application, which we've done some in lab. You want to choose the electrode type to minimize impedance. You want uniform conductivity. Remember, impedance is resistance in biological tissues. It should be easy. It should be hypoallergenic, cost effective. Variable size and surface area. So large enough to activate adequate number of motor units to avoid high current density and skin irritation, especially when stimulating large muscle groups. So that's a wordy way of saying large electrodes for large muscles and small electrodes for small muscles. So we want to find the motor point. To place our electrode on the motor point, we're going to get the most effective muscle contraction. And we did this a little bit in lab. If you're not getting the muscle um, response that you want, you can move the electrode around a little bit to see if you can get closer to the motor point. Remember, the motor point is the neuromuscular junction where the nerve synapses with the muscle. And so remember also with electrode placement, the closer they are together, the more superficial it is. So if you're getting larger muscles, you probably want the electrodes farther apart so you can recruit deeper lying motor units with large pads. So the size depends on the muscles you're going to stim. So if you're doing a smaller muscle, if you're doing like wrist extensors, for example, you probably just small muscles. You want to cover the maximum surface area of the muscle, but the placement should be wide enough distance to maximally recruit deeper lying motor units, especially for large muscle groups. So like hamstrings and quads, you're going to have big electrodes spaced far apart. For smaller less deep muscle units, you're going to have smaller electrodes, maybe closer together. So you want to orient your patient and educate them what they expect so that what their sensory response is going to be, what their motor response is going to be. What should they tell you about? And patients learn very quickly what to report. People will say, oh, it feels too bitey in this particular area, or that, they'll, as long as you have good communication going, they'll tell you right away. You don't want to disillusion to them to the fact that it's going to be a little bit painful, or it's high sensation, we'll say. You can decide whether it's pain or not. You want to look at their skin and make sure that it's intact and that their sensation is intact. So you might do some sensory testing. You want to monitor the patient response during the treatment. If they report discomfort, you want to check their skin. If there's redness after you take off the electrodes, tell them to look at it within the next 24 hours and see how long it takes for the redness to go away and see what their response to the treatment was. So, if they don't have redness under the electrodes, I usually don't mention it. But if they have redness, I tell them should go away within 24 hours. And if it doesn't, let me know at the next session. And some people will even take a photograph and send it to me, which that's super helpful. I like that. So we're going to talk about the specific applications. These are a bunch of references. Read them if you like. And we'll talk about the specific parameters for specific applications in the next section.